Good morning. Thank you very much for the kind invitation. It's a real pleasure and honor to be here this morning and to just discuss among us some of the recent thinking related to HIV, aging, comorbidities, especially frailty. I have to begin, however, by apologizing. I was hoping that the breath of fresh air from Quebec would not be a cold one. When I left, it was warm, but it's a little chillier here today, so I apologize for that. So just a little background from an aging perspective. So certainly when I started being clinically involved in patients with HIV, we had no idea where we were going. As you know, those among us who have been here for the long haul will very clearly remember. And even 15 years ago, I think at the start, 20 years ago now, at the Vancouver conference when HART first became available, I think for us to have envisaged a headline like this would have been the realm of dreams, or I'll smoke whatever you're smoking today type of thinking. But we've come a long way, and it's been absolutely amazing. Obviously for the people who are living this, and for the care providers, I think it's been this tremendous awakening, if you will. So basically what we can say today is that somebody who's diagnosed in their 20s can expect to live up to about the age of 70, 75. Now, obviously, there's going to be differences. There are very clear differences on gender and on risk behaviors which will affect this. But overall, survival is about 80-85% of what you would see in people who are HIV negative. But the interesting thing is that a significant and an increasing subgroup of this whole population are those individuals who have an undetectable viral load for more than 5 years and who have a plateau CD4 count of more than 500. And the best mathematical modeling that we have today suggests that these people will have a normal long-term survival. Now, to be able to say those words, I think, is absolutely amazing, and a real tribute to everybody who's put in so much effort over the years. Now, the consequence of the improved survival is that the clinical tableau has changed, and as opposed to people, just from the metric of, as you said before, we are all eventually, mortality will be 100%. The question is due to what? And as people live longer with well-controlled HIV, what we're seeing is that AIDS-related deaths are obviously decreasing. Everybody's aware of that. But that non-HIV morbidity and mortality is increasing. So I want to focus a little bit on that and to show you what we mean by this. So forget the left-hand panel, which shows you what are the causes of death in people with HIV. Overall, about a third, 25-30% of all causes of death are due to AIDS, classic AIDS-related complications. But if you exclude those, and you just look at what are people dying of who are not dying of AIDS, basically about 20% of mortality is due to non-AIDS malignancies, which I'm not going to focus on. Another 20% roughly is due to liver-related complications. And that's primarily in people who are Hep B and Hep C co-infected, but not necessarily, because we know that you can get non-viral hepatotoxicity from a number of complications, alcohol, some antiretroviral toxicity, etc. Cardiovascular disease is a huge problem, and that accounts, again, for about 15-20% of all causes of death. And then you have everything else being some infections, but not the opportunistic infections that we classically associate with AIDS, etc. So those are the major causes of mortality. However, before you die, what are the comorbidities that are occurring? And this very nice study by my colleague from Italy, Giovanni Guaraldi, what it shows is on the left-hand panel are the number of comorbidities by decade of life in HIV patients and the number of comorbidities in a concurrently evaluated sample of HIV-negative individuals, so positive and negative. And what it basically shows is that every decade of life, people with HIV have more comorbidities, but they're not AIDS comorbidities. They're common comorbidities such as diabetes, cardiovascular disease, bone demineralization, etc. And I'll come back to this a little bit later. So what we see is that the common non-AIDS comorbidities in people with HIV are the same as what we usually see in an older HIV-negative population. So these are similar comorbidities occurring on average, and there's obviously details, but on average 10, maybe 15 years younger in HIV patients who are well controlled from an immune and a virological perspective. Now, what is anticipated is that in the next 15 years or so, the number of comorbidities that this population will have will increase. So now you may have, most people have with HIV who are well controlled, don't have any comorbidities, any of these non-AIDS comorbidities, and this will increase over the next 10, 15 years. So if we then focus on the aging, because as people are not dying of AIDS, they are living longer. So what's the summary from what we see? The mean survival, as I said, is about 80-85% of what is expected in the uninfected population. And 50% of people living in resource-rich countries are older than 50 at the present time. This contrasts to less than 10% in the early 80s, at the beginning of the HIV epidemic. And the reason for this increase in age is very obvious. Most infected people are living longer, they're doing well with antiretrovirals, but also we have very good evidence that the age at new seroconversion is getting older. Comorbidities, as I mentioned, are similar to that that we see in older individuals. More or less the consensus in terms of response to treatment and the type of therapies that we have available, and we certainly have a lot of very different, single drug regimens, etc., which you'll hear more about this week at CAR, but most of the regimens are likely equipotent, equidurable, and thank you very much, and are well tolerated. There may be difference in toxicity and an adherence pattern, and there's some emerging data which suggests that possibly integrase inhibitor-based regimens may be more age-friendly, but that data is just starting to be available. Now, the age of the general population with HIV obviously is, as it's increasing, what we're seeing is that now the median age is 50, so 50% of people are over 50 years of age. But within the next 10, 15 years, we anticipate that 2/3 of people will be older than 50, and about 20-25% will be more than 60 years old. So what we are seeing now is that we're seeing comorbidities which generally occur in people in their 50s, similar to the pattern of what we see in people 10, 15 years older. In the next 10, 15 years, this group will be in their 60s, and they're going to pick up even more common comorbidities. And that will obviously have a significant impact on the overall clinical status and quality of life, et cetera, and all the issues that you're going to hear about today. So from there, as older people pick up comorbidities, what we're also seeing is an increase in this whole diagnosis of frailty. So what is frailty? It's one of those things that can mean different things to different people. But basically, the concept of frailty was developed in the geriatric population about 10, 15 years ago. It's a term that really became much more common in that time. When I was training as a resident, we didn't use the word frailty very often, other than in a very generic sense. But clinically, what it means, it's an age-related decline in multiple organ systems, physiologic systems, which leads to increased vulnerability to small stressors, which can have a major impact on an individual's overall health status. And the consequence of being frail is that this independently leads to a loss of independence, need for living in a supervised setting, increased risk of dementia, and increased risk of developing more comorbidities, and an overall increased risk of mortality if you are frail. The problem is that there's multiple metrics. There's several ways of saying this individual is frail, this individual is non-frail. And although they are very useful clinically, and I'll go over the major ones, there is no consensus on which one to use, and they sort of identify slightly different types of individuals. So as I mentioned, the consequence in the general elderly population of frailty is that increased risk of hospitalization, multimorbidity and mortality, increased risk of malnutrition if you're frail, loss of independence, increased risk of dementia, and obviously mortality. Now, in the context of HIV, as I mentioned, what we're seeing is we're seeing these age-related comorbidities occurring in younger people. Immune senescence, which refers to a normal physiological decline in immunity, it's occurring earlier in well-controlled HIV individuals. There's obviously the increased risk of cardiovascular disease, as I mentioned, bone demineralization, metabolic complications, diabetes, dyslipidemia, etc., renal and hepatic complications, and certain malignancies, not the malignancies that we typically associated with HIV, like Kaposi sarcoma and certain types of lymphoma, but there are different malignancies that are occurring in otherwise well-controlled HIV patients. But also, in what we see is that there are certain conditions that are occurring in HIV patients, which are common to what in geriatrics we understand are sort of the classic geriatric syndromes. And in addition to frailty, we're seeing a very high prevalence of social isolation, polypharmacy, disability, which refers to, officially the term disability refers to the inability to do at least one activity of daily living independently. Increased risk of falls is something which is getting a lot of attention in HIV, and we're all aware of the increased risk of the non-dementing cognitive decline that occurs in otherwise well-controlled HIV patients. And this study from UCSF, recently published, shows that the prevalence of typical geriatric syndromes in this population. Now, you're aware that San Francisco has an older population, a very well-established older population of well-controlled HIV patients, but you can see here that the prevalences of mobility impairment, urinary incontinence, falls was 25% prevalence in this population. Visual impairment, which is something that we don't pay enough attention to, depression, as you mentioned, cognitive impairment, not dementia, but mild cognitive impairment, which Dr. Bruyette is very extensively involved in, and difficulty with activities of daily living was very, very common in this older but well-controlled, and I keep using the term well-controlled because I think it's time that we moved on overall in terms of looking after our patients, just from saying your viral load is undetectable, your CD4 counts are great, thank you very much, I'll see you in a year. We need to move way, way beyond that. So multimorbidity and polypharmacy go hand in hand. The more complications you have, the more chances are that you're going to need some sort of medication to treat those comorbidities. And we know that older HIV patients obviously have more comorbidities equals more drugs. Polypharmacy is very common in the HIV population, and officially polypharmacy in the non-HIV population refers to taking more than 5 different classes of drugs. It doesn't mean how many different drugs you are taking every day. You may be taking, you have, for example, with the one-drug regimens with HIV, you're taking one pill, but they contain 3 drugs. Or you may be taking several drugs, one drug several times a day. So the number of pills is different from the number of classes. So you may be taking lots of medications even if you're only taking 1 or 2 classes. So you can see how this interaction is. And we're all aware, especially as you age, that polypharmacy is associated with increased risk of complications. And the expected increase in polypharmacy in the HIV population is going to become enormous, again, within the next 10 to 15 years. And with all the associated downstream complications associated with polypharmacy. This is an interesting study out of France in an HIV-negative population, but basically it said if you are both frail and have polypharmacy, that combination puts you at a very higher risk for overall mortality. Okay, so I think that's something that we need to keep in mind, and we need to work very closely with pharmacists in our, not only in our general HIV population, but particularly in our aging HIV population. So how do we operationalize the frailty? In the general population, there are several classification schemes that I've mentioned. The one that's usually discussed is the frailty phenotype, which was developed about 15 years ago by Linda Fried, and it's basically a syndrome related to poor nutrition, sarcopenia, which refers to loss of lean body mass, weakness, and impaired exercise tolerance. The other also very effective way of diagnosing frailty is use the Frailty Index, which was developed in Halifax by Ken Rockwood, and I'll go into some detail about this. There are other ways of measuring or diagnosing frailty, and in HIV, the VA cohort, the VAX Index, may also be one that's used. So the Fried Index, the Fried phenotype has very specific ways of diagnosing weight loss, impaired grip strength, exhaustion, walking speed, and low activity. And if you have at least three of these, you are diagnosed as frail. If you have 2, you are diagnosed as pre-frail. If you have none, you are non-frail. Okay? And what the MAX cohort has shown using the Fried phenotype is that it occurs more often in HIV positive than HIV negative individuals, that a low nadir CD4 count increases the risk of being frail. The prevalence in untreated individuals at the age in their mid-50s of about 3.5% is what you see in an HIV-negative population about 15 years older. That asymptomatic HIV males with frailty before HAART are more likely to develop AIDS or die once they begin HAART, and frailty is a dynamic process in the general population. You can go back and forth between being frail and non-frail, but people who are HIV positive are generally more consistently frail at every evaluation. The cumulative deficit model of frailty, the Rockwood, the Frailty Index, is related to the accumulation of general health deficits. And the more health deficits you have, the more likely you are to have poor outcomes. So the Frailty Index has been studied in the HIV population, and what has been shown is that it predicts survival, poor survival, and that having a higher Frailty Index predicts the development of multimorbidity in otherwise well-controlled HIV patients. So is frailty in HIV patients, regardless of how it's diagnosed, the same biological entity as in HIV-negative individuals? And the answer is probably. Certainly the outcomes of being frail appear to be same in HIV-positive and negative individuals. So the take-home message, the best tool to diagnose frailty, still in evolution. Are reliable biomarkers, blood tests available for frailty? No, they are not. Can HAART help to avoid frailty? Probably, but we haven't yet shown that. So obviously the message is still treat early, treat safely. Interdisciplinary approach to looking after HIV patients has always been the only way to go. And that is even more important in now the HIV, as the HIV population becomes older. And we need not just the traditional nurse-doctor approach, but we need social workers, we need occupational or physiotherapists, we need pharmacists, we need mental health professionals to be working together as we take care of these individuals. So, are the 50s the new 70s as opposed to what's going on in the general population, where the 70s are the new 50s, the 60s are new 40s? Is this the reverse that's occurring in HIV? Let me leave you with a positive note. The reality is the following. A recent study looked at self-rated successful aging in HIV-positive and HIV-negative individuals, and what it showed was that 2/3 of HIV-positive patients, despite having comorbidities, polypharmacy, still self-rated themselves as being in the upper half of this overall successful aging scale. So I think that's a very positive note to end on. Thank you very much.